Hello, and welcome to North Shore Private Hospital's virtual GP education program. This session was recorded at a live Zoom session in April 2022. Could it be a brain tumour? Covers presentations, diagnosis, management options and outcomes. Our presenters are Dr. James Laban, neurosurgeon, and Associate Professor Michael Back, radiation oncologist. To gain CPD points for this session, use the quick log function on the RACGP website. 2 points per hour to a maximum of 30 points CPD activities can be easily logged by using the...
So I'm James Laban. I'm one of the neurosurgeons at North Shore. What I'm going to do is just pull up my presentation, I think, first off, while we have a little preamble. So my talk essentially is about the initial management and presentation of brain tumours. So I hope you can see that there now, and hopefully that will be full screen. Just confirm that for me, Wendy.
Yes, it's full screen. Well done.
Okay. So I'm a neurosurgeon. I specialise in brain tumours, facial pain, trigeminal neuralgia, and degenerative spine. Those are essentially my 1, 2, and 3. This talk is obviously focused on brain tumours. My background, you can tell from my voice, is that I was spent a lot of my life in the UK. In London, to be precise. So my heritage is that my mother was actually from Orange. My father came here from Europe post-war in the 50s. They met here, but decided to settle in London in the 70s. And I essentially grew up in London before coming back to Australia for fellowship. I did a fellowship in brain tumour surgery and in spinal surgery at North Shore Hospital, and then got the job that I've been working towards in the UK as Director of Neurosurgery in St George's Hospital, which is or was one of the biggest hospitals or largest teaching hospitals in the world. I think in the last 5 or 10 years, I imagine there various new builds in China and Africa and places which probably have superseded it, but it was certainly in the top 10 about 10 years ago, 15 years ago. But I always wanted to come back here, and I finally managed to persuade my wife about 4 to 5 years ago, and returned back here about 4 years ago. I took over Michael Biggs's practice. He was a senior neurosurgeon working here for maybe 25 years or so, and I've been running his practice for the last probably 3 years, maybe something like that. Anyway, so that was enough about me. I'm going to talk to you more about brain tumours and the diagnosis and initial management in general practice. So the indications and choice of imaging, and then also some of the pearls and the pitfalls for initial management. So this first little chart here just really highlights that although brain tumours are pretty rare, and for the base rate here, we can see that it's maybe 2 tumours per 100,000 for the younger population, but the incidence significantly increases when you get to the 60s, 70s and 80s age group, so where you're getting up to almost 20 tumours per 100,000 population. So it is rare for a GP to see one, but it's not vanishingly rare. You'll probably see maybe 1 or 2 every year, or at least 1 every maybe a couple of years of a newly diagnosed brain tumor, or come across them in your practice. Main symptoms here, this is just an overview, you know very well: vomiting, mood swings, cognitive decline, hearing problems, really looking at acoustic neuromas, headache, speech problems, and seizures. And the things we all worry about are the increased intracranial pressure, which you can remember from your medical school, or if not, more recently, with the changes in levels of consciousness, papilledema, vomiting and headache, pupillary changes, and then the one that everyone always thinks of, which is the Cushing's response, increased blood pressure and decreased pulse. So that's an end stage response. So when we see that in ED, I think I've seen it once in ED. It's an end stage phenomenon. Typically, you're seeing that in ICU after a patient's had various treatment or treated palliatively. It's very end stage. So the Cushing response is not something you'll see in general practice, I hope ever, because that means that the patient is about to die in front of you. But the other things we know well about intracranial pressure, the main one here that I'm going to talk about for a little bit is headache. And the reason for that really is because of the impact that headaches have on your services as general practitioners. So about 4 patients out of every 100 will present to a general practitioner over the year with headache. So it's a large burden of your work. But obviously you've got to pick out of those which patients do have brain tumors or need scanning. The annual incidence of a brain tumor we talked about already, maybe 1 in 10,000 over all the age groups. But as I said there, 80% of them patients will be over the age of 50. So that's one little indicator that you can look at. The likelihood of a patient with a headache having a brain tumor is 1 in 1,000. If you are able to make a diagnosis of tension headache or cluster headache, a primary headache phenomenon, or migraine, the risk of it being a brain tumor does reduce from that 1 in 1,000 to 1 in 2,000, but it's still up above that annual incidence of 1 in 10,000 that we see in general population. So what we need to do is try and pick out which patients with those headaches, what are the will have a brain tumor, what are the red flag signs. So some of the main red flags here, this is people that have these presentations and will have a more than 1% chance of having a brain tumor. So that's a headache with a focal neurological symptom or sign. It's a new onset of cluster headaches, or new onset cognitive deficits, new onset seizures, a previous medical history of cancer, and especially breast, lung, melanoma, kidney, and gastrointestinal with one of these phenomenon, or papilledema. So papilledema is one of these things that we always talk about. It is somewhat difficult sometimes to really diagnose. And that's because you're in a bright clinic. You may not have your ophthalmoscope readily available. Maybe the batteries aren't working. Maybe the viewfinder's not working on it. But in general, if you can have if someone presents with a headache and you are able to have to do fundoscopy on them, you only need the briefest look because you're looking for major findings with papilledema. I'm not expecting, and no one expects a general practitioner to pick up one of these kind of loss of venous pulsations or venous engorgement or elevation of the optic disc. If you can do that, great. But they're more difficult to do and you need much more training. What I would say is if you are interested in doing it, just start to do it routinely, and hopefully a lot of you are doing it routinely anyway, especially with your diabetics and so forth. But you can see there is quite a striking difference between a normal optic disc and that one with papilledema. And you only need to really see one of the optic discs well, or reasonably well, because papilledema is almost always bilateral. And you're looking for the blurring of the optic disc margin or those retinal hemorrhages. Those are the 1 and 2, really. The Peyton's line is something else that you can look for. But really that 1 and 2 is blurring of that optic disc margin and those hemorrhages. If you see those, then that's really cause concern. But a lot of what you're looking at is from your clinical acumen before you're even picking up your ophthalmoscope. So these orange flags, these are the kind of symptoms that someone is presenting with, and the risk of them having a brain tumor is around 1% or between 1.5%, something like that. So it's something to take seriously. So obviously a new headache in a patient over 50, I would take seriously. Headache on waking, headache with vomiting, headache with exertion, or if patients have a long history of migraines, not uncommon, and they have a sudden change, this, particularly if there's a sudden increase in the frequency. So those are all things that you should certainly take more seriously, and maybe be reaching for your fundoscope for, or arrange a further review, or just go straight to an MRI or a CT or whichever scanning imaging preference you have. We can talk about that in a second. So this is one of my little questions here. Which of the following is the most common presenting symptom of brain cancer? So this is from work that Professor Back did, looking at all the brain cancers that presented over a 3-year period. So if we have a little look here at the options: personality change, generalized seizure, focal seizure, motor deficit, headache, speech disturbance, or visual disturbance.
I've just launched that as a poll for everybody. You can press the button and give us your choice, your preference there.
Hopefully we'll be able to get some interest in answering this question.
Can you see those results coming in, James, or not?
No, I can't see those results.
Okay, all right. Sorry, I thought I'd allowed that to happen with the way I set it up. We've got some coming in, so we'll just give another few seconds. You should just be able to press a button on your screen and participate in the poll.
Michael, you're not allowed to join in. You know the answer.
Okay, we've got some people have answered, so let's end the poll there, and I'll share the results. Are you there, James? Can you see those?
Headache. So that's quite interesting. So headache, 70%, focal seizure, personality, 10%. And the headache is certainly the most well recognized. And I think the reason for it is twofold. Number one is that headache is such a common presentation to general practice. And number two is that after the fact, after the diagnosis is made, often people do report headaches once they kind of told the diagnosis. So if we can move on and close that, and we'll give you the actual answer here, hopefully. Is it back to me? And there we go.
Yeah.
So it was in order. So personality change is in fact the most common. And when if you after the fact go back and see and ask the story, and nearly that this research was done on brain cancer, but nearly all brain tumors have a degree of personality change if they're symptomatic. So headache actually will be later on, and there'll be often some background of many months or years of just some subtle changes, but you'll have to almost ask directly about them in some cases. And often when we describe, or the ED doctor describes the presenting complaint, it will be of something more obvious to us, such as a focal seizure or a motor deficit. Talking about someone's lack of concentration, inattention, visuospatial, executive disorders is much more difficult for us. It's not a common language for us to use, or things that we often look for as practitioners as a whole, as medical professionals, unless you've got a specific interest in neuropsychology. So certainly look for personality change there. I mentioned this or touched on it already. So what is the imaging modality of choice? So the patient comes in for you, what investigation would you be looking at if you were suspecting they may have a brain tumor? They come in with maybe a severe headache, maybe some personality change, some visual disturbance. So we've got skull X-ray, CT brain, MRI plus minus contrast, MR spectroscopy, or PET scan, FET, FDG.
We've got some answers coming in, James. I'll just give it a little bit longer. Nearly everyone's answered. So I'll end it there. And can you see those results now, James?
Yep. So all of those are fair answers. I'm pleased that no one said skull X-ray. That was maybe 30 years ago. So CT brain. So the advantage of CT brain is you can get the answer, and the access to it is, it's got easier access, and you tend to be able to get a CT quicker and more easily. but the sensitivity of it is much less than an MR. So I would have chosen MRI brain as the number one. If an abnormality is seen on the MRI brain, they can give contrast afterwards, because we've got to take into account that you may be imaging people with just cluster headaches or tension headaches, etc. Maybe it's just a change in the semiology of their migraines. So rather than giving contrast to everyone, I think an MRI brain is the first step, and then the contrast can be added by the radiology company following the radiologist's review. So that's what I'd be requesting as the general practitioner, MRI brain, given all those caveats. The other imaging that we've got there is the MR spectroscopy. So that's really advanced imaging, as is the FET and FDG PET, which Michael kindly enables us to get for our patients. And that's really for advanced imaging for patients that have a brain lesion, typically thought to be low-grade glioma, sometimes of uncertain etiology, and it just helps us delineate exactly what that brain lesion is. It's also helpful in the follow-up of brain cancer treatment. So certainly I think the MRI brain for a general practitioner, seeing someone with headache and some maybe personality change, that would be the investigation of choice. The contrast the radiologist or radiographer can add in, and there should be, I've not seen to memory brain tumor that's been missed because of a lack of contrast on an MRI. More frequently, what happens is the flare sequence will show up a non-enhancing tumor that is given contrast and doesn't enhance. So that's much more common. So non-contrast MRI brain. So hopefully that. So this is just a case history of someone I saw last week. I've got a urgent access, rapid access slots for brain tumor patients, and this was a 40-year-old right-handed male. He was a butcher. His presenting symptom as such was actually recent visual loss. So he described to me being unable to read his iPhone anymore, and on examination he could only see movement out of the left eye, and he could only count fingers out of the right eye. So he had significant visual loss over the last 6 weeks or so, and especially within the last couple of weeks. But when you asked him about his background, and he was there with his mother, I always try and make sure that they do have a relative with them when I see them, at least one relative, if not more. And there's this background of him being unemployed for the last 2 years. He lost his job because he didn't care anymore about his job, and he didn't particularly care about losing his job either. And then more recently, he'd stopped watching WWE, which was something he was very keen on, and he started going for walks at 3 o'clock in the morning. So those symptoms had been going on for some months before this recent visual loss that he became symptomatic of. And one of the reasons that he presented so late with this large frontal tumor that you can see on the right there was because that frontal tumor was causing that personality change, that apathy, that abulia, that lack of will, that lack of drive. And he'd failed to really notice that there was any significant change and didn't really care about it. So that large lesion there, extra-axial, homogeneously enhancing, and it's basically compressing and displacing the whole of the frontal lobes bilaterally. The reason for the visual loss is because of the high intracranial pressure, and he was diagnosed with papilledema and then got the MRI and then was sent to me. So that was the order of events. So the types of brain tumor, so the split into two main types, as you know. Metastatic, so look for a previous medical history of breast, lung, melanoma, kidney, gastrointestinal tumors. In about 10–15% of brain metastases, it's actually the first presentation of cancer. So they may not have a previous medical history of any cancer. And in another 10%, we never find the primary. That's reducing with molecular markers, but still with a reasonable number, particularly of aggressive or poorly differentiated tumors. We're never quite sure whether the adenoma carcinoma is from maybe lung or gastrointestinal origin. The second main type of brain tumor is primary, so that's when it's from the brain itself, or calvarium, or brain cavity, or brain parenchyma itself. And they're split into benign, which is the WHO 1, grade 1, or malignant, which is the WHO grade 3 or 4. So the most common types are meningiomas, from the lining, from the meninges, gliomas with WHO 2, which are your low grade gliomas, or 3, which is your more aggressive anaplastic gliomas, and they come under the malignancy or glioblastoma, and that's WHO 4. So the low grade gliomas are the ones which are less aggressive than grade 3 or grade 4, which both are seen as malignant. The issue is that there are some 120, 130 different brain tumors, and the classification here is the latest iteration of it. It continually changes. I think it's changed 2 or 3 times in the last 15 years. And particularly with the molecular markers, it's continually changing. So it's not really helpful to go through all of the different types for you. It's just a knowledge that there are many, many different types, and the treatment of all the different types does vary quite substantially. You can see the meningiomas over on the right-hand side there, or on the left-hand side, the anaplastic oligos and the glioblastomas and so forth. So if we look at another case history here, there's a 78-year-old gentleman, a retired businessman. I saw excellent GP referral list. So 10-day history of headache, had a previous history of ischemic heart disease with coronary stents on medication there, Cartier, Bergamet, Esotrol. No significant findings on examination. Bloods were normal. ESR was normal, so not giant cell arteritis with this sudden onset of new headache in a 78-year-old. So investigation of choice, MRI, which the GP had arranged, and it showed this left temporal lobe intraaxial lesion with some mass effect and some surrounding edema, and it was favored to be either a high-grade primary tumor or a metastasis. So the GP contacted my secretary, I think, or my mobile directly, I think it was my secretary, and asked whether I could see this patient as an urgent. This was we can talk about the management options, but the question here is, what's the ideal management? So either sending to the emergency, start anti-epileptics, stop Cartier, urgent outpatient neurosurgical review, CT chest, abdomen and pelvis, or dermatology review. And Wendy, I don't know whether they can click more than one.
I didn't give that option.
Sorry, I should have told you to do that.
Yeah,
okay, so you've got to choose your favorite out of that. We can discuss them all.
Yep. I've got a few results.
Best answer.
Sorry.
And this is of the ideal management.
Yeah. Few different options coming through. Anyone else want to have a go?
A bit harsh. Ideal management.
Okay, we've got some answers there to talk about anyway. Here we go.
Perfect.
I'll share those. Can you see those now, James?
Yep. So I think that's pretty good split, I have to say. So we can talk about this. So sending to ED, certainly that's a very safe option. It's something I'm trying to encourage general practitioners to move away. And the reason is that this gentleman and the people that you see generally, or almost always because they've come to see their general practitioner, relatively well. They're not someone attending emergency department because they've suddenly collapsed. They're someone who's relatively well. This patient had no focal neurology, just had headaches, and was otherwise well. And what happens when you send the patient to emergency department is typically you'll see them, I don't know, 10 o'clock in the morning or 2 o'clock in the afternoon. They'll go home, get some things, go to the emergency department, turn up at maybe 4, go be triaged, then be seen by the emergency practitioner. There'll be handover happening on the wards. The neurosurgical intern or the neurosurgical registrar will get down to see them maybe towards 8, 9, 10 o'clock when they'll be transferred to the ward, or when they're transferred to the ward at 10, 11 o'clock. And then they'll maybe be seen on the busy business ward round the next day briefly by a team of 20 people as they're all walking past. And they'll be left there with probably very little information and no one having time to really talk to them and explain what's going on. And often the next management, particularly for this patient here, will be stopping the cardiac and waiting 7 to 10 days till the aspirin's out of the system before they can have any surgery, getting a scan, so the CT chest, abdomen and pelvis. I think that's a very good option there, because we do want to know whether this is a primary or a secondary. We want to know whether the patient's got a large lung lesion that may affect anything that we do neurosurgically. Maybe they've got cancer everywhere. It may be one of those 10% of metastases that's the first presentation. So CT chest, abdomen and pelvis, definitely. Dermatology review, I think, certainly is very reasonable, particularly with this tumor. It had some of the characteristics on some of the MR sequences of potentially being a melanoma. And I think that an urgent outpatient neurosurgical review is the ideal thing, because that enables a patient to bring someone with them, to have a sensible talk with someone in daylight hours about this life-changing diagnosis that they have. The key really is that they need to be seen urgently in an outpatient setting. They don't need to be seen in 3 months' time, and that would be totally inappropriate. So you have to have a neurosurgeon that you trust, that you can contact, a practice manager that you can get in contact easily, and someone that has availability. And I keep 1 or 2 slots open every week to see brain tumor patients, as we've seen already. So certainly you can always feel free to contact me or my practice manager about these patients. And that really is much better for the patient pathway. One of the things I set up as director of neurosurgery in the UK was an urgent access clinic, so that these patients that were diagnosed with new onset brain tumors in the public system could be seen in the public system in an urgent neuro-oncology clinic within 3 days or so. And I think that's really key, and it's much better quality of life. The length of stay in the hospital is reduced, and the overall patient experience is much better. So the other thing I've said here, so send to ED, ideally not in a fit and well gentleman or someone who's presenting otherwise fairly well. Start anti-epileptics. So it's somewhat debatable, but essentially starting anti-epileptics routinely on brain tumor patients who does more harm than good. There's more complications associated with the anti-epileptics than there is a reduction in seizures. So I certainly wouldn't be starting an anti-epileptic as a general practitioner. I think the neurosurgeon or neuro-oncologist or neurologist that sees a tumor and can opine on the probability of it causing a seizure, I think that's reasonable. But as a general practitioner, you shouldn't start anti-epileptics. Certainly stop cardia, that can change drastically. When I was working as a fellow, I would not uncommonly see people that had a scan maybe a few days earlier, maybe in another hospital, taken 3 or 4 or 5 days to be transferred. And then when they were transferred, they were still on aspirin or some blood thinner that you then had to stop. And then that just prolonged their stay by maybe a week or so, sometimes longer. Dermatology review, start dexamethasone. I think that's something that the neurosurgeon and neuro-oncologist should be doing. It's not unreasonable if there's a lot of mass effect, but if there is, that's someone that needs to be seen urgently anyway. So I would leave the steroids to the neurosurgeon or neuro-oncologist. This is just a Cochrane review, the latest Cochrane review, I think 2008 maybe. Looking at anti-epileptics, they conclude it's neither for or against, but there was a slight increase in adverse events with anti-epileptics. So I think I wouldn't start them as a general practitioner. So we've got another case history here of a 71-year-old male, presented with 2 years of ataxia and dysmetria and slurred speech, but really when I asked about it, a 6-year history of some cognitive deficits as well, some visuospatial executive problems. You can see there as an accountant, he shouldn't be getting that first one wrong. And his family was saying he kept missing out on conversations or joining in halfway through a conversation that had happened 3 days earlier. Background we can see there, he had this MRI which showed this extraaxial probable meningioma in the region of the pineal. He had a reasonable previous medical history, as you can see there. So this kind of patient is a slowly progressive tumor, but it's not small. It's about 3 centimeters. It's obviously causing significant and increasing problems. And particularly in the last few weeks, he had a few falls. But he was still independent at home. And so rather than bring him into hospital and do the workup over weeks, it was someone that I brought in as an urgent, managed to arrange his MRI brain, the whole spine scan, tumor markers, and then he had some hydrocephalus, so we did an endoscopic third ventriculostomy just to divert the fluid from the hydrocephalus, and he needed a bubble echo as well because he had a sitting position surgery, which is something that I think a few neurosurgeons have expertise in or have experience in, but something that I did quite a lot of in the UK. And I started on dexamethasone. So again, able to really hone down his length of stay, was able to have a conversation with him and his wife and his daughter about quite complex needs that he'd have over the coming kind of weeks and months and so forth, set everything up, and much better than in having a conversation with an RMO at 11 o'clock at night that doesn't really know what the plan's going to be. These are some intraoperative imaging. They're just pretty pictures basically for me to show off. There's the ETV in the top left, the first one, the approach, the second one's of me making a little hole in the floor of the third ventricle, the other one's a sitting position. The bottom left shows the meningioma on approach, and then the bottom right shows me having excised the meningioma and a view into the third ventricle, but we won't focus on that because it's not so interesting for you.
So I've got a question. That sitting,
yes.
The sitting surgery, they're asleep, aren't they? They're not.
Yes, yeah. So I do awake surgery, but that's within a sleep. Okay. So this patient that Michael knows well as well, 28-year-old right-handed banker, had partial seizures after a run, after exercise, had this previous medical history of Lynch syndrome, what I'd call hereditary non-polyposis colorectal carcinoma. It was a family history. It was very, weren't really totally certain whether he'd actually had genetic testing or not, and it's still somewhat obscure to me, but certainly there was a family history of it, and he was on Cartier for the Lynch syndrome. He'd had an MRI. He then went on to have MR spectroscopy and F and FDG PET. Thank you very much to Professor Back, who organised those things for us. And all of those things favoured a low-grade glioma. He had Keppra with the input from neurology. I always, when people are started on anti-epileptic, if they've got a seizure disorder, then I do always involve neurologists. I think it's important. They can follow the patient up and tailor their anti-epileptics as appropriate. So I actually removed this for this gentleman, and this is the histology that we get nowadays. So it's very complicated, and increasingly so as we're able to get next generation sequencing and molecular genetics. I think Professor Back is going to talk a bit about, and it means that really obtaining histology is increasingly important because we do tailor our treatment to it. These are some of the prognosis. I think, again, Professor Back is going to talk a bit about these. Really, what I wanted to highlight is, number one, from my point of view, the importance of maximal resection or maximal safe resection. This is from America here, which I love that phrase, maximal safe resection rather than biopsy or subtotal resection. And then the importance of the genetic markers there, or molecular markers. And on the right, you see the Kaplan-Meier curves. The top one is the probability of survival, with the blue line showing survival with a better performance score. So whether the patient's independent and mobile is very important for prognosis. The bottom one is from the nurse practitioner point of view, and the specialist nurses and the carers. So that's for caregivers, the importance of having a good or specialized caregivers. And we're lucky enough to have a couple of nurse practitioners on board that specialize in cancer patients and specialize in brain tumor patients. And I'm going to move swiftly on, very briefly talk about things that aren't brain tumors, so arachnoid cysts, pineal cysts, colloid cysts, and so forth. Arachnoid cysts, they're developmental, incidental, very, 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 very rarely require any intervention at all. The only thing that I do have is a conversation about the increased risk of intracranial hemorrhage were they to have a significant fall or injury. Pineal cysts, again, very, very, very rarely require any intervention. The bottom right just shows this news article from a somewhat notorious neurosurgeon that I think is no longer practicing at the moment. Was fairly infamous in neurosurgical circles for taking out pineal cysts or treating them. So pineal cysts essentially do not require any intervention, but they do need to be differentiated from pineal tumors like the one we saw. Colloid cysts, these are probably developmental, but may slowly enlarge, and they can cause sudden death. So this is a good example actually of someone I treated, I think 2 weeks ago. He was a 25-year-old admitted to Royal North Shore Public. And I was actually contacted to go and see him because he wasn't happy that he felt like no one had spoken to him and he had no idea what was happening. And he asked me to take over his care, so I brought him across to the private. These are again some images just for me to look at. Really, that's showing the colloid cyst obstructing the foramen of Monro, and that's why it can suddenly kill people with this sudden hydrocephalus. Probably that's what happens. And there's the post-operative image on the right showing the foramen of Monro now open and view into the third ventricle. Dermoid cysts, they're linear growth, so they tend to grow very slowly. They can resemble arachnoid cysts, which is why if you do get an arachnoid cyst, I think it's always reasonable to get someone to double check the MRI for you. And then finally, brain abscesses. And those patients may be afebrile, have normal white cell count and CRP. The risk factors are there, and there is that risk of growth or rupture into the ventricle. So those need to be taken very seriously. Hydrocephalus. And then the nice final picture of recurrent glioblastoma, the Professor Back kindly referred me. He was presented with increasing speech problems and had been declined surgery by one of my colleagues because of the location of the recurrent glioblastoma in the primary speech area, so in Broca's area. But with some of the latest technology that we've got just now in North Shore Private, it shows this tractography showing the fiber tracts and under awake conditions. So with the patient awake, I was able to entirely excise that tumor, and he went home and was able to have another Christmas and another birthday with his family, which they were very happy about, with his speech much improved. And that's me. So I hope you enjoyed that and you got something out of it, the way that brain tumors present and some of the first management for them. Always happy to be contacted about anything. My practice manager is excellent, but if you wanted my mobile as well, then by all means, I'm happy, Wendy, for you to give that out. People ask for it at the end.
Okay, thank you, James. I've got a couple of questions here. With MRI brain, when is it required to add MRAI?
MRA?
Yes. Yeah.
So if you're suspecting some vascular abnormality, so really the reasons that I'd be adding in an MRA is to look for an aneurysm. So I would really only be doing that if we're screening, but probably most screening for aneurysms, I would have I'd refer to a neurosurgeon first or a neurointerventionalist first to have a conversation about that, so they understand the importance for it. So follow up for aneurysms and MRA, or if there is history of moya or so forth. Those are rarer things, rarer conditions. So rarely would I, as a general practitioner, be organising an MRA off the bat without having a neurosurgeon or neurointerventionalist or neurologist ask for it, or some kind of screening or suggestion first.
Thanks, James. I don't know if you could just flick back to case 3. Someone's asked which tumour markers in case 3 patient.
Yeah, so that's those are rarities. So it's because it's in the pineal region. So this is really specific for pineal tumours, and you look at alpha fetoprotein and beta HCG, and that's for yolk sac tumours or choriocarcinomas, which this didn't look like, but just for completeness for pineal tumours, I think it's important to do because it can significantly change the treatment of them, and you do the same for the CSF markers as well. But in general, with tumour markers for brain tumours, not particularly helpful. You're going down the lines of a CT chest, abdomen, and pelvis, and then removing that brain tumour if you think it's a metastasis and you don't have any other diagnosis and it's large or symptomatic.
Thanks, James. I can't see any other questions at the moment, but if anyone has any further questions for James, feel free to put them up there on the chat and get those at the end. So we'll pass over now to our next speaker, Associate Professor Michael Back. And I'll let him introduce himself and start sharing. You can start sharing your screen once. Can you figure out how to take that one off, James?
There we go.
Yep, there we go.
Great, thank you. And thank you for the opportunity to provide this session today. I'm a radiation oncologist and a neuro-oncologist. I only manage patients who've been diagnosed with brain tumours and get my referrals through the neurosurgeons. I'm based at the Royal North Shore Hospital as Director of Radiation Oncology, but I also work at a number of hospitals around Sydney, including North Shore Private Hospital, Mater, Macquarie Uni, St Vincent's, Hurstville Private, Northern Beaches, and I've got a large practice at Central Coast, and also look after patients from Orange and Dubbo on site there. A lot of my patients with brain tumours, while they're getting treatment, can't drive, so we set up the practice so that we can deliver care closer to their home for convenience for family and the patient themselves. Neuro-oncology is a changing sphere, and as James mentioned, the classification of tumours has changed a lot in recent years, and including the last classification of the WHO, which usually only changes their classification for malignancies every 10 years. They've changed in 2007, 2016, and then they've just changed again in November 2021. So we're dealing with a new language of brain tumours, and I'm going to try to bring that through a little bit today as well, and what the impact of that is on our own patient care, the care of the patient in the community, and also detail some of the features associated with prognosis in that way. Okay, so the discussion today is really about the decision-making for neuro-oncology interventions. And these are some of the points I'll be discussing: the classification of brain tumours, understanding prognosis, the basics of radiation therapy and chemotherapy as it applies to brain tumours, some of the survivorship issues that you might face with your patients in the community, and also one that we have to face, and that is the modes of death of patients with brain tumours, because that's what really impacts in the community as well, and the families, and you're probably going to get a lot of, or get patients' families coming through to you, and that'll be one of the questions they may be asking in how they have to prepare for a relative who may have a brain tumour who might be going to pass away or in the terminal phase of their illness. But firstly, the classification of brain tumours. So as James mentioned, the WHO provides a classification, and this has changed a lot in recent times. So for today's session, I'm really going to concentrate on primary brain tumours, and predominantly the gliomas. Brain metastases is another form of brain tumours that we manage a lot, and James mentioned those. But for brevity today, I'll just concentrate on those primary brain tumours. So the classification does come down to histological structure and grade, as James has mentioned, but the recent changes that have happened, as occurring with a greater understanding of brain tumours has come through understanding how these brain tumours work, how they grow, what stimulates them to grow, and what genetic changes are associated within the tumour that may precipitate that growth. And that has now been brought out in the classification processes as now requiring molecular analysis or molecular status of our brain tumours to try to work out what type of brain tumours they are. So in the past, it used to be the neuropathologist just looking down the microscope at the brain tumour sample, doing some stains, detailing what the structure of the tumour looked like, and acting on those stains to try to work out what type of brain tumour it is. That's no longer the pathway that has to be undertaken. The classification or to diagnose a brain tumour correctly now requires molecular analysis to be performed on these tumours. So we have to send them away for sequencing to work out what sort of proteins might be activated within the tumour, and distinctive patterns of tumours then develop. And these distinctive patterns will be associated with different prognosis and also with different treatment options. So it's now an integrated diagnosis. We use the histopathological techniques, so the classical ones we've always done, but also now the molecular status. And why it's become subspecialized, because at the moment, although the WHO recommends this as a necessary way of classifying tumours, it's actually not covered by Medicare. So it has to be done almost in a research setting in the major teaching hospitals for it to be completed. And in other centres, the diagnosis might be left with a caveat on it to say that it can be classified under the WHO so long as you get further testing. So it's become quite complicated, but here's some of the details that are brought out. So with our tumours, we classify them under the microscope as being high grade or low grade. And also for primary tumours or primary gliomas, they fall into either an astrocytic pathway or a oligodendroglial pathway. So they're the two major types that we see. But the prognosis varies significantly within those. And historically, when we saw our patients in the past, they would say have a grade 3 tumour, and we would say that there'd be a 3-year survival of around 35, 40%. However, we didn't know which patients would fit into the ones who were more likely to be alive 10 years down the track or the ones who would die at an earlier time. And so as a result, it was just really an averaging, because the patients within that group of, say, grade 3 tumours were really a whole lot of different tumours and a whole lot of different clinical scenarios. And that's where the molecular basis has really come out. The molecular analysis has really helped to clarify that a bit further. And the key thing which has come out is what we call IDH mutation status. So that's a mutation with the isocitrate dehydrogenase, or IDH. And if the patient's tumour has got that mutation, it's a more favourable mutation, and it's a more favourable outlook and better response to therapy. If they don't have that mutation, they're IDH wild type, and that's more unfavourable. So in a patient such as the one that James presented before, if they present with a biopsy which says this is a grade 3 tumour, there may be a vastly different natural history. And the key to unlocking that natural history, or the prognosis, it really comes down to that mutation status. Now, we didn't know about IDH mutations back in 2010. In 2011, 2012, we started to begin the testing of it. In 2016, it got incorporated into the WHO classification, and now it's formally within the classification systems for most of our brain tumours. So the IDH is a very key thing for our patients, and you might see that in the letters we send back, and it does demarcate a significantly different prognosis. So just here's an example of some of our data from North Shore in patients with grade 3 glioma. And if in the lower blue line there, they're the patients who don't have the IDH mutation, and the curves up the top of the patients with the mutation. And this is years down from time of diagnosis or time of radiation therapy. So the molecular classification provided a very easy way of determining the differences between the tumours in outlook. And that then brings us through to prognosis. One of the key things that patients obviously are concerned about when they come through and they've been recently diagnosed with a new glioma and they've been given a predominantly Latin term for the tumour. What does that mean? What does the prognosis mean? And they may come to you to get some further clarification. I guess one of the messages we've tried to send through to the community before has been that these prognoses have significantly changed over years because we're now grouping patients better. And also the prognosis has improved as our treatment techniques and caring for patients has improved. So when we're understanding prognosis, the two methods we usually use to describe it is median survival, which is the survival time which 50% of people are alive and 50% of people are deceased, and overall survival at a particular time point, such as 2 years, 5 years, or 10 years after diagnosis. So we look at our own data here in patients with glioblastoma, which is a grade 4 tumour. 95% of those patients will be IDH wild type historically. And now patients who have got IDH mutations don't fall into the glioblastoma subgroup since November 2021. But if you look at our historical patients with glioblastoma who are predominantly IDH wild type, who don't have that mutation, then the median survival of our patients is around 18 months, and the 3-year survival is about 20%. So that's a pretty bleak outcome for our patients. So that's improved over time. We've been using radiation therapy since the 1970s and 1980s for these patients, but the addition of tablet chemotherapy from trials performed in 2005 doubled the amount of people alive at 2 years. And since then, even though it's predominantly the same recipe, our median survival has improved and we've got more patients alive in the sort of 3 years or 4 years after treatment. We don't have too many patients with that pure glioblastoma subgroup who are alive at 10 years, but we do have some patients who do continue to do well, and we try to unlock the reasons for them. There are certain subgroups where we have a lot more patients alive at 5 years, and that's another molecular test which comes out in the molecular analysis. If those patients have got that particular subgroup, and that's in around 20% of patients, then if they've got that and all other factors are similar in terms of extent of resection and performance status, then in that group of patients, about 20 to 25% of people are alive at 5 years. So really, these sort of details that come out which impact significantly on patients' prognosis. However, we look at patients who have got a IDH mutated tumour, and our patients with grade 3 IDH mutated glioma, then the survivals are a lot better. The median survival of our patient group with reasonable follow-up has not been reached, and the overall survival at 10 years ranges between 60 and 75%, depending if those patients have got an IDH mutated astrocytoma or the IDH mutated oligodendroglioma, with the oligodendroglioma subgroup doing better at 10 years. So there's a marked difference in the survival, even though the tumours might look very similar under the MRI and might look very similar under the microscope. So this is a case study of a young lady, just very briefly, who's been diagnosed in the last couple of weeks. She's 40 years old, and she had a brief history of a headache and left facial droop. So minimal symptoms. Her general practitioner provided a CT scan in the community to investigate this, and it demonstrated this bulky right frontal lobe mass. It was contrast enhancing, it had a solid component, cystic component, and significant mass effect. So she was taken into hospital and she had a good resection performed and came through the procedure without any deficit. So it was a good result from the surgical procedure, and the mass effect has improved significantly, and she's now got no symptoms. So under the microscope, the neuropathologist looked at the sample and saw around the cyst wall significant cell density consistent with tumor. There was proliferation of small blood vessels, suggesting this is probably a high-grade tumor. And there was an infiltrative border, even though the tumor looked pretty well demarcated. In the area of the tumor, there were oligo-type features, and oligodendrogliomas that classically have a fried egg appearance, where there's a cell density in the middle and white around the edge, and that was looking like an oligodendroglioma. It showed on the proliferation indexes a varying range from 10% through to 40% to suggest this is an active tumor. But the neuropathologist came through with the results and said this is a glial tumor, was proliferative and high grade, and the features were consistent with a grade 3 oligodendroglioma. So that was reassuring to the patient. We send the tumor away for molecular analysis, and that takes around 10 days to come back. So in the 10 days after the operation, the patient's managing with the tumor, waiting for the final classification of the tumor, but the features were consistent with a grade 3 oligodendroglioma, which, as we demonstrated before, fits in this curve here with a 60 to 70%, or probably more like a 70 to 80% 10-year survival after the good resection and good performance status. So she's come through that procedure well, and we followed her up in the clinic, getting ready to deliver the next range of treatment based upon the grade 3 oligodendroglioma status. And the molecular pathology's come back, and it didn't show any IDH mutation. It showed the presence of what we call a TERT mutation, another abnormality, and some other subtle molecular changes. And this tumor was now classified as being consistent with a glioblastoma IDH wild type. And that 60 to 70% chance of her being, or 70% chance of her being alive at 10 years down the track, based upon her prognosis, now falls down to a median survival of 18 months. And we could see the differences there, and this is sort of not an unusual appearance. We do some of the IDH mutation testing at time of the initial view that the pathologist does, but in 10 to 15% of patients, you may not see that mutation at that stage, and you need to wait for the molecular analysis, and we just presume that was the case with her. But this now has the features of an IDH wild type tumor. Her treatment's completely different. The molecular analysis has changed not only the treatment, but obviously the prognosis for this lady, and a whole lot of other issues subsequent to that. That's the way that the molecular testing and the pathology has really changed our practice. So after a patient has the diagnosis and the tumor is classified, then they come through to the treatment pathways. James has gone through the surgical techniques and the recovery, and then most of the times there's a combination for the higher grade tumors and the more unfavorable lower grade tumors of going straight forward through to radiation therapy, and in most cases now oral chemotherapy or chemotherapy tablets, generally a tablet called temozolomide. So just a little bit of a primer on radiation therapy. So radiation therapy is high energy X-rays. They're targeted and precise. We individualize the treatments to the patients, and the treatment regimens are designed to damage the tumor cells but allowing the normal cells to repair. Our profession has completely changed with the onset of digital imaging, and as a result, software has changed as well. And whereas I started as a specialist back in 1996, and I used to draw with crayon on a plain X-ray to design treatment techniques, generally a limit of about 2 fields, which would be rectangular prisms in shape. We now do everything via 3D reconstructions of brain, and including 4D adjustments for movement as well. So a patient will come through, we do a 3D reconstruction of their brain and where the tumor is, and design the treatment from there. For patients who go through brain radiotherapy, I give them 3 basic tips, or 3 sort of messages, which hopefully will give them some confidence to get through. One is that how they walk into the radiotherapy program is generally how they should tolerate it. So if a patient gets through the initial insult of the surgery and gets through the surgery okay, then generally, especially if they had a good resection, they'll manage well with the radiation therapy afterwards. Secondly, most of the side effects are dependent not on just radiotherapy, but which part in the brain the tumor is located. And it generally comes down to swelling. So I say it's a bit like irritating a pimple. If you've got some tumor left behind, when we give the radiotherapy, it inflames the area, and that can cause more swelling in the brain, and we then have to give medications such as steroids. And most of the symptoms come down to that sort of paradigm of swelling. The third tip, and this is a really crucial one, is mobility is the key. We've actually got to keep patients mobile. If you're mobile, you'll live longer and you'll enjoy life better. If patients stop working, then we want them walking. So we want them active. We say there's no cotton wool in the department when they're having brain cancer treatment. Now that doesn't apply for all types of radiation therapy, but when treating a brain tumor, it's not associated with any systemic illness. So patients aren't unwell for the rest of their body. We can make them unwell by causing some metabolic changes or giving medications, anticonvulsants, steroids, which might upset them. But generally, they're not unwell. So we've got to keep people mobile. If you're mobile, it's a general index to say that you're going to live longer. If we start giving people lots of steroids and they're not mobile, then they get the proximal myopathy and they get difficulty with getting up out of the chair, difficulty with walking, have asymmetrical weight gain, fluid retention, and you get a lot of complications related to that. So the key thing is mobility and keep people walking. We cause tiredness with treatment, but if we get around the tiredness by keeping people active, so doing a 20-minute walk in the morning or a 10-minute walk in the morning as well as one in the evening, then that generally will keep some of the energy levels away and keep their body functioning. In terms of pathways during the course of radiotherapy, the initial part is target design. We make a mask of patient's face to keep them nice and still. Then we do a 3D reconstruction of their brain. We now know that tumors just don't grow as balls. Tumors grow down pathways in the brain. So we design the treatment to push the dose down pathways. And that way we can be much more accurate at what we do and minimize the dose to normal brain. These pathways are the basic white matter tracks, and we see tumor crawling along those pathways. They're not growing as round spheres in the brain. So in that way, we can be much more directed, and we use the MRIs and the PET scans and our knowledge of where those pathways are to design the treatments. Then the 3D reconstruction allows us to hit a target, and in the days gone by, a therapist used to sit down in front of a computer and work away and do programming, and it would take a day and a half to get a plan out. Now the plan comes out in an hour and a half. It's all artificial intelligence driven, and the optimal beam arrangements then arranged, buttons pressed, plans produced, and then we can do the final quality assurance checks, and patients can start in a well-organized department within a day or so. So it's actually much more sophisticated treatment and much more patient-friendly. And then we can deliver the dose to the brain, which minimizes the dose to normal brain structures and hits the targets in the brain. And in the old days, we used to try to keep everything nice and even. Now we want to put high dose in certain areas, lower doses in different areas, and then try to balance that off against the metabolism of the tumor and try to hit things much better. And as a result, our control of tumors is improving. The number of our patients with glioblastomas who are alive at 2 years or 3 years down the track has really increased in recent years. And the quality of life is also better because less of the normal brain has been treated. And that's what a machine looks like. On the machine, there's not only where the beam comes out, but there's also we do a CT scan on the bed. So every day before treatment, a patient has a CT scan to localize themselves or an X-ray to localize themselves. So it's all image guided, targeted and directed, computer driven, and the human error part of it hopefully is then minimized or eliminated, and the treatment's accurate to 2 to 3 millimeters. The chemotherapy comes in with the radiation therapy. It's often given at the same time as the radiotherapy for the very aggressive tumours, or it might be given afterwards in the sort of 6 months after the treatment for the less aggressive tumours. So there's different recipes in which you use, but essentially it comes down to a tablet drug, which is generally well tolerated. It doesn't knock over people's blood counts very heavily. The drug's called temozolomide. So it's different to injected chemotherapies or the chemotherapy you might have for lung cancer or breast cancer, which might cause more changes in the bone marrow. There's still some rules with it, but it's generally a tablet taken at home with some anti-nausea medication by the patient each morning during their radiotherapy, if they're having it concurrently. Or if they're having it afterwards, they probably have it for 5 days every month, so Monday to Friday, and then 3 weeks off. The chemotherapy is not the only drugs that we use. We have a lot of supportive therapies, so the dexamethasone or corticosteroids is used, and we don't mind juggling those doses around. We avoid getting lazy and keeping people on high doses of dexamethasone for long periods because of the side effects of it. And we prefer to bring people up and down on their steroids and try to find that optimum level if they do need it. James mentioned about the anticonvulsants, and the trend is to move away from routine anticonvulsants after an operation. But there's certain times when you do require them, and some patients get a bit more reassurance by having them, and so as a result, they're instituted. Some patients use them if they've had some swelling in the brain, we might use that. And I guess we try to avoid the dramatic effects of having a generalized seizure. But there's very minimal evidence to show that prophylactic anticonvulsants really do a lot in terms of minimizing the risk of a seizure. The most common one we use, or the most common ones used, is Keppra. And the biggest issue for that is that it can sometimes cause some mood changes. And we juggle or rotate the anticonvulsants around if we're seeing side effects to particular drugs. As James mentioned, it's often good to get a neurologist involved if there's more than one anticonvulsant that's required, or if it's a more complicated seizure profile. For the supportive therapies, there's also this drug called Avastin, which I'll mention a little bit later on. And Avastin's being increasingly used. It's an injected drug, which is actually a cytotoxic, so it works against tumor cells. It's a targeted therapy, and it kills off tumors by stopping the proteins which produce new blood vessels. So it's an antibody therapy. But we use it in the place of steroids to reduce down the amount of steroids that are required. It's a very good drug for quality of life to reduce down the pressure in the brain, though it does have some potential side effects which could be quite severe if not managed appropriately. In the last 2 years, it's become PBS listed, which has allowed the increased access to the drug. The most important part of the treatment often is not just the delivery of the treatment, but the care that comes afterwards. And the key in looking at patients is following them up closely with the MRIs, which is generally done in the clinics, through the specialist clinics. And we need to compare MRI progress as we go through. So it's not just the one MRI, we need to look at multiple MRIs and see the pattern. So here we have a tumor in the left insular area after radiotherapy, getting smaller bulk, and 12 months later is still reducing. And this is a IDH mutated tumor, which is reducing slowly over time, which is exactly what we want to see. Other times we see this picture where you get a lot of swelling in the brain. So the area where the tumor was sitting has become much more inflamed and swollen. And that's a condition called pseudoprogression, where there's a lot more swelling happening in the brain. It's an inflammatory process that comes up over the course of treatment and then goes down. But on the MRI and to the patient and to a radiologist who doesn't know the pathway that the patient's being treated on, it can look like recurrent tumor. So the challenges in the clinic are often not delivering the therapy, but following the progress of the patient in the 3, 6, 9 months after treatment. And it's really following that MRI progress and trying to work out whether this is true tumor progression or whether it's treatment-related swelling. So the survivorship issues that come up are multiple, and there's multiple domains which impact on it, and how our patients manage after treatment or with a brain tumor. This is just a couple of ones I'll throw in here for discussion. Patients who have got high-grade brain tumors are at increased risk for DVTs or pulmonary emboli. It occurs in about 15% of our patients. So it's not uncommon. Any calf swelling, any breathlessness, or any unexplained agitation is generally deemed as being a potential symptom that could be related to an underlying clot process. So any tachypnea may be associated with clots. These clots can occur at time of initial diagnosis or can occur in the follow-up period. Some of the drugs we use, such as Avastin, can increase the risk of those clots as well. So it's an important one for the community practice, that if something's changing in a patient's general condition, if they're getting systemic symptoms, it actually might be symptoms of an underlying thrombosis. And the CTPA is, we've got a low threshold to ordering CTPAs or Dopplers as needed. The general way we manage this is with Clexane therapy. Some of the DOACs are being used now, but we still haven't got good data on patients with primary brain tumors and oral anticoagulation, so we're still keeping up with Clexane. Employment and driving, we actually encourage our patients, even with the grade 4 tumors, to continue their work abilities if they see that as appropriate, if they're fit to do that. About 20% of our patients in our published series of patients with glioblastoma work during their radiotherapy, if they get through their operation okay, and 60% have returned back to work at 6 months after treatment. Work not only raises revenue for family, but also gives people purpose in life, and it's an important part of that person's independence. And we work with their employer to try to get them back into the workplace. Driving, there's generally a limitation after the surgical procedure, but the vast majority of our patients, if their tumor is under control and they've got no significant swelling, will return back to driving. And of our patients with IDH mutated tumors, 75% of patients return back to driving at 5 years after treatment, or remain driving at 5 years after treatment. It all depends on what their scan's looking like, and they're subject to periodic medical review. Cognitive issues really depend on which part of the brain's being affected by the tumor, and generally, because the radiotherapy is much more targeted now, if the patient gets through the operation okay, then we're generally not adding to those cognitive issues if we're giving focal therapies. The final two there are issues which come up in the community, and sometimes they scoot straight past us, and you might have to deal with that in the community. That's managing the uncertainty that's associated with these tumors and the prognosis. And that's why it's important to get a reasonable understanding of what prognosis is in our patients. And we use a lot of psychological supports, and we'll often send patients back to the primary caregivers to arrange for local psychological supports or mental health plans. And likewise, the carer is important. James showed one of those slides beforehand, and carer mastery, how all the patient's carer manages with this diagnosis and the impact on their family, how the carer is managing, has been shown in one study to be an independent prognostic factor for survival of the patient. So a lot of our roles try to augment care understanding. They've got a sort of an email pathway to us. They've got a cancer care coordinator who works closely with them in the community and in the hospital, so that if there's uncertainties happening, it's usually the carer who's raising the hand rather than the individual patient, and that's a very important aspect. Finally, it's sort of a point we need to discuss on is, how do these patients end up dying? We are trying to manage patients in the community, but things have changed in recent times in the pattern of death that patients die from in the community. And that's because we're using this drug Avastin. So Avastin is used in the majority of our patients now, and it actually changes the natural history of the tumor after relapse. And it's associated with improved survival duration. It's not curative, but it improves survival duration and improves quality of life. because it really does reduce down the mass effect in the brain by turning off the blood vessels. Here's one of the first patients in Australia to receive Avastin. Big swollen area in the brain around the surgical cavity with a recurrent tumour, and then within 2 weeks, that's come right down. Patient's symptoms have improved. It's a temporary measure. It wears out after about 5 months, or 3, 4, 5 months, but it can work to reduce down the pressure in the brain. It doesn't generally stop the tumour infiltration, and thus what happens is that the natural history changes. This is some data from our practice up at the Central Coast, where in the days before Avastin was sponsored by the PBS, patients could co-pay, and the patients who couldn't co-pay, their average length of survival, once we made that decision, was around 28 days. In the patients who could co-pay, the average length of survival was around 4 to 5, or about 6 months, I think, in this series. And it also allowed a further treatment option to be used with re-irradiation with Avastin. So Avastin changed the way that we're managing patients and was generally well tolerated. But it is an impact, initially because of the financial cost, but now it's supported by the PBS through data such as ours. And so what that does, it reduces the mass effect in the brain and tends to control some of the mass effects. So patients used to die before from increasing raised intracranial pressure and with symptoms related to increasing pressure in the brain. But now the pattern of death is changing more to where that mass effect's being controlled by the Avastin, and you get later infiltration in the brain through down to the brainstem. And so the mode of death is altered. So here's a patient who has got a recurrent tumour up in their frontal lobe, and the Avastin's controlled all the mass effect up there. We can see the normal gyri associated with it, so that the tumour's being controlled there, but the tumour is infiltrated all the way down into the brainstem, not causing mass effect, but does produce a different symptom profile for patients. So we're now seeing different patients presenting with gait disturbances, with nausea, or with vertigo type symptoms as part of their final symptom cluster, rather than headaches or reduced level of consciousness. Avastin also, when we were in a situation where patients' general mobility is going off and they're getting to this stage, when we stop the Avastin, it actually provides some control for the patient and the family, because when they stop, the pressure builds up over a period of 4 or 6 weeks, and that then leads to the patient's death. And so it allows a bit more control in planning of those final stages. So it is different, and you will see this in the community, the way that our patients are proceeding through that terminal phase. And it's a different mode of death compared to patients historically which had raised intracranial pressure and then would go through a pathway of coning from that raised intracranial pressure. So that's a little bit of a focus on gliomas and what happens to your patients as they're going through this diagnosis pathway. We're optimistic for the future because we're getting a better understanding of the natural history of tumours and IDH and the way the tumours progress through the brain, but there's still a lot of challenges ahead for our patients and for all the caregivers, including the primary caregivers in the community. Thank you.
Thank you so much. It was a really informative presentation, Dr. Burke. I've got one question only at the moment. What does IDH stand for?
It's isocitrate dehydrogenase. If you go back to year 1 biochemistry at med school, I've got no idea where it is in the cell cycle, but it's somewhere there, but it's pretty important for brain tumours. Right. So that's the way we know it. Now, the interesting thing about it, just a quick thing, is that IDH is in the tumour, but not in the normal brain. It's mutated in the tumour. So if we can get a drug which blocks the IDH mutation, then we can deliver a therapy which stabilizes the tumour but doesn't affect the normal brain function. And there's now IDH mutated IDH blockers coming through. They're very new and they're not available routinely, but they're a potential hope for the future with patients with IDH mutated tumours. And there's also vaccines against the IDH mutation which are being trialled.
Interesting. Any other questions for our specialists while we have them? I failed to mention that we co-branded this event with the Brain Cancer Group, which is a charitable organisation. Our CEO, Richard Ryan, is on the board. Michael Back is on the board. James, are you involved in the Brain Cancer Group?
No,
charity
I'm
as
not
well?
on board at the moment, but yeah, I fully support it, I have to say.
Yeah. So that's a great charity as well. The other thing that we alluded to during the presentation was a cancer care navigator. So North Shore Private have recently employed Pilar Lee. She's got a nursing background as well as a social work background, and her role within North Shore Private is to liaise with recently diagnosed cancer patients and help them navigate through that treatment pathway from diagnosis through to survivorship. We've also got a new program at Hunters Hill Private Hospital. It's also running at Mount Wilga Private Hospital called Activate. So not just for brain cancer patients, for any cancer patients who you feel may need, we know exercise is key and keeping moving is key. So Activate is a multidisciplinary team of physiotherapists as well as OTs and social workers as well. And they provide a program of over a series of weeks providing exercise and getting people moving who are going through cancer treatment. So you can refer directly to that Activate program. There's information on that on the Hunters Hill Private website, but some of our specialists will start referring into those programs as well. So you may have patients that enter that Activate program at Hunters Hill or Mount Wilga Private Hospitals. If you've all got those web details, we might finish up. We're 3 minutes early. So thank you again to our speakers, and thank you to all of those who attended tonight. We look forward to seeing you next month. I'll let you know.